one city, College of Medicine. I must say that I am truly honored to be back here in the Philippines, my second home, to share with you the most important aspects of wound management. And before I begin that, I want to thank Colonel Alias for the invitation to come and speak. Pleasure to meet the two generals for your kind and wonderful hospitality. Today, I want to invite you all on a journey with me to understand the clinical management of wounds. And we know that wounds can be the harbinger of many diseases, more comorbidities, as well as mortality. My colleague, who's a very well-renowned wound care specialist, Dr. Ford, has a non-clinical definition of a wound. And this is a very good analogy to the military. A wound is a battlefield where the skin is losing the fight. A battlefield. We have the opportunity as physicians and clinicians to take a clinical problem and turn it around to a point of clinical resolution. Not only to heal the wound, but to restore the quality of life to our patients. We see here a wound which is a breach or a deficit or a void in the largest organ of the body. And the medical word for that is the integumentary system. The derivation of the word integument from the Greek means rind. So the covering of an orange, the covering of a lime or lemon, is the integument of that fruit. So when you have a breach in the integumentary system of the largest organ of the body, could you believe the potential morbidities and mortality that can arise from this? And as a former professor at St. Luke's Hospital in Chicago, of course I'm going to ask you some questions. So I have the first question. What did Christopher Reeve die from? Don't say kryptonite. He died from an infected bed sore. So with all of his resources, his financial resources and his healthcare resources, he died from an infected bed sore. This could be the harbinger of bad things to come if we do not arrest and treat this type of condition. So let us begin on this journey this morning. There are three phases of wound healing. We have the phase 1 inflammatory, phase 2 proliferative, and phase 3 the remodeling. All of these phases do not start in stock. They occur overlapping. And phase 1 inflammation is the body's natural response to injury. And here's what happens. We have blood vessel constriction. We have the thrombocytes, the platelets coming down to clot and clog those leakages, because we don't want to exsanguinate the patient. We want to conserve the hemodynamic status of that patient. And we have the macrophages, also called the garbage truck cells. They come around and they remove devitalized tissue. Phase 2 is called the proliferative phase. This is the most important phase in wound healing. This is where we take the fibroblast, which I'll talk about in detail this morning. The fibroblast being the most important cell in getting the granulation tissue to develop to get that wound to a point of resolution. So here's what happens. We have contraction of the wound, it becomes smaller, and the fibroblasts establish a collagen base. They establish a scaffolding, a template, a matrix in the wound, and from that matrix, we will have the emergence of granulation tissue. And then finally, phase 3, which can be a long, protracted period of time. We have new collagen contributes to the reinforcement of the tensile strength of the skin. Does the tensile strength of the skin ever come back to 100% after a wound is formed? No. Maximum 80% tensile strength. Important to know that. Because then, if it comes back 80% and the patient re-injures it, we have a case of wound dehiscence, wound failure. Okay. So this is a slide just reiterating the slide previous, where we have a sequential relationship of inflammation, phase 1, migration proliferation, phase 2, and remodeling, phase 3. All right, now collagen. Why is collagen so important? And here's why. The dermis, or the skin, is made up of 90% type 1 collagen. It's the most abundant protein in the body, and it's in the form of a braid, a triple helix. That triple helix is very tightly coiled in order to be able to form the integrity, the structural elementation of the skin. So if we have a deficit on the integumentary system, we have a wound, doesn't it make sense to replace that breach or that deficit with collagen? Absolutely. That's the theory. That's the clinical protocol and the perspective as clinicians we need to incorporate and say, well, if we have a wound, let's put collagen in there to reinforce it. And that's the simplicity of wound healing. And this is what the molecule looks like. It's made up of amino acids, and we know amino acids are the building blocks to proteins. There's a sequential order of amino acids: proline, glycine, hydroxyproline, and here it is in this tightly rigid coil. This original state is called a native intact strand of collagen. And the reason why I mention that is because I'm going to talk about the differentiation of collagen, why we use native intact versus modified collagen, which is better clinically. Okay, the fibroblast. As I said before, the fibroblast is the most important cell in wound healing. And a military analogy I can give you, the fibroblast is the 4-star general of wound healing. Without fibroblasts, we can't heal a wound. And here's what happens. We see that it is important in the structural integrity of the connective tissue. Every organ has 2 major components: the parenchyma and the stroma. The parenchymal tissue is the functional tissue of the organ. Like the lungs, the alveoli are the parenchymal structure of that organ. But the tissue that maintains the integrity of the bronchi and the bronchioles and all the other structural aspects is the stromal contingent of that organ. The same thing in the skin. The same thing in the spleen. The same thing in the liver. A lot of organs possess parenchymal structures and stromal structures. So the fibroblast is the 4-star general that reinstitutes the stromal integrity in the tissue, in the integumentary tissue, which is the largest organ in the body. Okay, so here we see the collagen works with the fibroblast, polyglycosaminoglycans, fibers, and glycoproteins. Look at this very interesting cell. It has a branched cytoplasm, a very elliptical nucleus, and it's a specialized cell. Another analogy is a specialized cell of the heart. The myocardial cell has a very unique physiologic property. If you take 2 myocardial cells, separate them in a petri dish, they beat independently. If you bring them together, they beat as one. That is called an organ of syncytial response. Syncytial. Cooperation. It's like the military. It's like the integration of the military. You're all separate in your different divisions, but yet when you come together, you beat and operate as one unit. Same principle in the body, particularly with this fibroblastic structure. And we see a lot of granules in the nucleus. A very large abundance of rough endoplasmic reticulum means that it's an active